So I acknowledge the contribution of Dr. Deepa Agrawal in making this presentation, and we do receive research grant support from Alcon Laboratories. So the primary challenges are getting a good measurement in children, what formula to use, and the target refraction. In older children who are able to sit up and allow us measurements on a machine, obviously we go and calculate as we would do in an adult person, except for the target refraction. But majority of pediatric cataracts are, uncooperative, which is children less than 3 years of age. And therefore, they are likely to require examination under anesthesia, not just for IOL power calculations, but to actually also look at the eye, whether it's actually a cataract or a fetal vasculature, retina, conioscopy, glaucoma, so on and so forth. And if possible, the best way to measure the keratometry would be using handheld autokeratometers. And if you're unable to access that or unable to do that, if it's a relatively otherwise normal eye, you can also go for the standard case based on the age-matched normative database that have been published way back in 2008. So it's steeper when the child is younger, and it tends to become flatter as they grow by 3 to 4 years. It's always a better idea to measure the axial length with immersion biometry because contact can be inaccurate. The major challenge in children would be to get that bulky Prager shell inside the eye, because some of these eyes are very small. So for example, we've got it customized, got that Prager shell made by a local manufacturer for different smaller sizes as well. But if possible, we must try and get an immersion axial length rather than a contact, because contact, even in pediatric eyes, has been shown to be significantly less accurate than the immersion biomicroscopy. The IOL power calculation formulas, unlike adults where we have 2 or 3 very good formulas which we can blindly rely on, children, the literature is completely divided. And that's because each pediatric eye is very different based on whether it's unilateral, bilateral, age of surgery, so on and so forth. So several papers have given several different options to consider. We've analyzed our own data, which we published many years back, and we find in our hands the SRKT or the Holiday 2 seems to work the most accurate as far as pediatric eyes goes. In the target refraction, the main question is, should we undercorrect, and if yes, then how much? So the principle of undercorrection is that, you may have a greater chance of getting amblyopia just now, but if you correct them well with spectacles, the chances of developing very high myopia when they grow up is much less. Whereas the theory for emetropia is, which means very little undercorrection, is less amblyopia now, but the chances of developing very high myopia after when they grow up is quite high. So the general consensus is to undercorrect. And how much to undercorrect for that age is a very important factor determining the rate of the axial length. And the maximum phase of axial length occurs in the very early phases, which means less than 1.5 to 2 years is the time when the axial length grows the most. And it's also more in children less than 1 year, and it's higher in pseudophakic eyes compared to aphakic eyes. And the rate of axial growth is higher in a unilateral pseudophakia, which means a unilateral pediatric cataract, compared to the normal non-operated eyes. So unfortunately, the eyes do behave little abnormally. So undercorrection is the key word, and it depends on the age of the child, laterality of the cataract, and whether the child is already myopic for the age or not. And there are several nomograms, the commonly used ones being the Trivedi and Wilson nomogram, where based on the age, they have a fixed post-operative refraction which they target. Younger the child, 1 year plus 6 diopter, so on. So older the child grows, less the undercorrection. And typically around 7 to 8 years, we stop undercorrecting very much. We've developed our own strategy with our own database, and this is something that we follow, that for very young children, less than 6 months, we undercorrect by 30 to 35%. And as they grow older, we tend to undercorrect them lesser and lesser. And anything more than 6 or 7 years, we hardly undercorrect them. So let's take this case, for example. Age of surgery of this child was 4 months and 20 days, bilateral cataract, and had normal axial length for the age, 18.6 diopters in both eyes. So keeping that in mind, less than 6 months, so we did the calculation and did a 30% undercorrection. The emetropic power was 36, so 30% reduction would mean about a 26 diopter power, which we implanted in both eyes of this patient. And this has been the child's refractive history from surgery until now, 5 years post-operatively, where he's left behind with very little hypermetropia, but there's been no great myopic shift. And present day vision with +1 and +0.75 hyperopia for distance is reasonably good. What about toric IOLs in children? I think toric IOLs can be considered. First of all, the child needs to be older than 5 years of age. So literature has shown that about between 5 to 7 years of age, the keratometry stabilizes. And then the major changes occur then only after 30, 35, 40 years of age. So we published this data on visual outcomes of toric IOLs in pediatric eyes undergoing cataract surgery, and it's the largest cohort of pediatric eyes with toric IOL published so far in the literature. And we found that definitely there is a significant reduction, a predictable reduction in the post-operative corneal astigmatism lasting even up to 3 years, which was the follow-up published data. And they remain stable even with the posterior capsulorhexis or an intact posterior capsule. So they are effective in reducing astigmatism, particularly in older children. So I think to summarize, it's difficult to measure in children. There is no consensus on the best IOL formula. But I think using the SRKT Holiday 2 is good enough. Do appropriate undercorrection as per the age and the laterality. But most important is that the treatment of pediatric cataract starts after the cataract surgery, unlike in adults that once you operate the surgery, everything is over. Here, the amblyopia therapy and glasses and lifelong follow-up is the most important treatment. Thank you so much.
Excellent presentation as always.